Welcome to the video tutorial on outcomes of plea clinical trial IDWeek abstract 1974. So as we know that this plea clinical trial is the phase 3B clinical trial of Elores, in which Elores was compared to meropenem in case of ESBL positive infections for the patients of complicated UTI including acute pyelonephritis. So four abstracts of this study were published in IDWeek. So in this tutorial, we will have a look on the outcomes of the abstract 1974. So first, let us understand the objective of this plea clinical trial. So objective of this plea clinical trial was to prove that CSC 1034, that is Elores, is non-inferior to meropenem in treating ESBL positive infections for the patients of complicated UTI including pyelonephritis. So, in this plea clinical trial, Elores was compared to meropenem for the patients of complicated UTI, including pyelonephritis, and the infection type was ESBL positive infections. So, in other terms, or in other words, this plea clinical trial was conducted with an objective to generate evidences for assessment of Elores, that is CSC 1034, as a carbapenem sparing treatment for MDR infections due to ESBL producing gram-negative bacteria. So here we have seen a term that is MDR. So what is MDR? MDR is multiple drug resistant. So this MDR is that pathogen which is resistant to 3 or more than 3 classes of antibiotics. So if 3 classes or more than 3 classes of antibiotics are not working against a pathogen, then that pathogen is considered as a MDR, multiple drug resistant pathogen. And one of the mechanism for developing MDR is ESBL production, that is extended spectrum beta lactamase enzyme production, which causes development of resistance for a pathogen to multiple antibiotics. So from this plea clinical trial, evidences were generated to show that Elores is a carbapenem sparing antibiotic for ESBL positive infections. And as discussed, 4 abstracts of this plea clinical trial were presented in IDWeek. So in this tutorial, we will have a look on the abstract 1974, what was its objective, its outcome and conclusion, etc. So in this abstract 1974, the effect of baseline MICs on the clinical and microbiological outcomes at the test of cure TOC visit was investigated. So what is this baseline MICs and TOC? So baseline MIC. So MIC of Elores and meropenem at the time of admission of patient into the study, it was the baseline MIC, which means that the value of MICs which was taken from the first sample of the patient for AST report, that is antibiotic susceptibility testing, when they were included in the study. So it is known as the baseline MICs for Elores and meropenem. Now what is TOC? So in this study, the mean or average duration of treatment was 5 to 14 days. So this 5 to 14 days duration is known as EOT, that is end of treatment. So after this end of treatment period, the period of 10 plus minus 4 days after the EOT, end of treatment, is known as test of cure visit. So patients were called upon for follow-up visits and they were evaluated again. So this follow-up visit is known as TOC, test of visit, which was 10 plus minus 4 days after the end of the treatment, and this EOT, end of the treatment, is 5 to 14 days. So in abstract 1974, the effect of baseline MICs on the clinical and microbiological outcome at the test of cure visit was investigated. So let us know about this study in brief. So 230 subjects were randomized in the plea clinical trial, and out of these 230 subjects, 143 were included in the MMITT. So this MMITT is microbiologically modified intention to treat population. So what that means? So this MMITT, microbiologically modified intention to treat population, is, so these are those patients which has at least one baseline gram-negative pathogen at 10 raised to power 5 CFUs per ml. So this CFU per ml is the unit for to calculate the strength of the pathogen. So if any pathogen, at least a single pathogen, is present in the strength of 10 raised to power 5 CFUs per ml, and it is susceptible to both of the studied drugs, that is Elores and meropenem. So this category is MMITT, microbiologically modified intention to treat population, which means that the patient is having at least one baseline gram-negative pathogen at 10 raised to power 5 CFUs per ml, susceptible to both Elores and meropenem. So out of these 143 patients, 74 were in the Elores arm and 69 patients were in the meropenem group. And among these 67 patients, out of 74 patients in Elores group were Enterobacteriaceae, and 64 out of 69 in the meropenem group were Enterobacteriaceae. So Enterobacteriaceae population, if we talk about in this study, so out of 74 patients which were in the Elores group, 67 were Enterobacteriaceae and 64 out of 69 in the meropenem group were Enterobacteriaceae. So example of Enterobacteriaceae, it is Escherichia coli, E. coli or Klebsiella pneumoniae. So these are the examples of Enterobacteriaceae. And mean duration of IV therapy in plea clinical trial was 7 days. So now let us look at the important outcome of plea clinical trial shared in the abstract 1974. So the favorable clinical and microbiological outcomes were observed in 90% or more than 90% of the patients for all MICs across the both of the studied drugs, that is Elores and meropenem. But there was just an exception, which was MIC 1 microgram per ml in the meropenem group, which was associated with more than 20% of the failure. So 90% or more than 90% of the clinical and microbiological outcomes were observed across both of the studied drugs, Elores and meropenem. But there was an exception, which was meropenem at the MIC of 1 microgram per ml. So this 1 microgram per ml is the break point of meropenem, which means that if the MIC of the that particular pathogen is, if it is 1 microgram per ml or less than 1 microgram per ml, it will be considered as susceptible. The meropenem will be considered as susceptible. So at MIC 1 microgram per ml, in the abstract 1974 of the plea clinical trial, 20% or more than 20% of the failure was reported. So it means that out of 69 patients in the meropenem group, for patients in which MIC value was 1 microgram per ml, which is the breakpoint of meropenem currently, meropenem failed to show clinical response and microbiological eradication in more than 20% of the patients at TOC, that is test of cure. So as we can see in this graph also, which is also included in the LBL also, total of 21 patients out of 69 in the meropenem group were at MIC 1 microgram per ml, and clinical cure and microbiological eradication was seen only in 16 patients, and 5 patients failed to respond to meropenem therapy. But if you look at this data in the Elores group, at MICs up to 4 microgram per ml, there is 97% or more than 97% response. And overall, both clinical cure and microbiological eradication rates were higher in Elores as compared to meropenem, with 90% or more than 90% response. So here we can conclude that Elores showed a higher in vitro in vivo correlation. In vitro means the AST results which were done in the microbiology lab, the in vitro results, and the in vivo, that is the clinical cure and microbiological eradication of the patient. So Elores showed a high in vitro in vivo correlation of more than 97% for MICs up to 4 microgram per ml, and is a potential new treatment option in patients with complicated UTI, including acute pyelonephritis. Also, we can conclude that meropenem MIC at 1 microgram per ml was less predictive of sustained clinical cure in patients. and these warrant a re-evaluation of the clinical breakpoints of meropenem. So this study could be considered as the first indicator for initiating further studies to explore clinical correlation of meropenem at MIC, a level of 1 microgram per ml, and possibility of further revision of breakpoints to below 1 microgram per ml. So in this way, this study also warrants a re-evaluation of the clinical breakpoints of meropenem, because this 1 microgram per ml is the current breakpoint of meropenem as per the FDA, but at this breakpoint level, more than 20% of the treatment failure was observed at the test of cure visit. So this was all regarding the objective and the study design and the conclusion part or the results of the abstract 1974 of the plea clinical trial. Hopefully this video tutorial will help you in communicating the outcomes of this abstract 1974 to doctors in an effective way. So thank you, friends.